All right, guys, welcome back. And our next discussion will be about antibiotics. And antibiotics is a very important topic because not only will you get tested on it on exams, whether block or step one, but it's very important clinically because in rotations and in practice, you'll probably be prescribing antibiotics. So it's kind of important to be aware of antibiotics and know the ins and outs of it. As I always do, I kind of like to start with a big picture of what is it exactly that we're doing here. So the goal, as simple as it sounds, is to kill the bacteria or stop its growth. Now you're gonna think of how do we kill the bacteria? So, or how do we stop its growth? So the first, it might be helpful to think of the bacteria as, just having DNA, having proteins, having a wall, and we can intervene in each of these steps to stop the growth of the bacteria or to kill it. So the first thing is that we can inhibit new base synthesis. So we can stop making bases, and if you don't have any bases, you're not going to make any DNA. The next thing that we can do is that we can alter the DNA. So we can stop replication, or we can alter the integrity of the DNA. The next thing that we can do is that we can inhibit transcription. So let's say we made the DNA, we can inhibit transcription. So we can stop making mRNA. Um, and the next thing that we can do is that we can inhibit translation. So we can inhibit any protein synthesis. Um, and then the last two things is that let's say we were not successful in inhibiting base synthesis, we're not successful in altering DNA or inhibit transcription or translation, we can inhibit the bacterial wall. So the bacteria has a wall and we can inhibit this wall. So really antibiotics target any of these specific steps. And test makers sometimes like to, actually a lot of times, like to test on the big picture. Like, what is it exactly that we're doing here with this antibiotic? How does this antibiotic work? So with the first step is inhibiting new base synthesis. So we can inhibit folate synthesis. So we can use the medication sulfamethoxazole or trimethoprim or dapsone, and these inhibit folate synthesis. And as you know, folate is needed for DNA bases. And if we don't have any folate, we're not going to make any bases. The second step is that we can alter the DNA. So we can inhibit DNA over or under winding, because we know that as we're replicating the DNA kind of overwinds, um, and uh, and then we have these enzymes, the topoisomerase, that make these nicks to relieve the tension in the DNA. So fluoroquinolones inhibit that process. We can alter the DNA integrity, so we can make some reactive oxygen species in the DNA, and that's using metronidazole. Third step is that we can inhibit transcription. So we've made the DNA, now we want to make an mRNA so that we can translate that protein. So we can inhibit transcription. And a drug that inhibits transcription, specifically the mRNA synthesis, is rifampin. Fourth step is that we can inhibit translation or protein synthesis. And really, these are by inhibiting the ribosome. So there are medications that inhibit the 30S subunit, and there is medications that inhibit the 50S subunit. So the medications that inhibit the 30S subunit is aminoglycosides, tetracycline, or tegacycline. And the medications that inhibit the 50S subunit is the chloramphenicol, clindamycin, linezolid, and macrolides. Fifth step is that we can inhibit the bacterial cell wall by inhibiting the building blocks. So as you know, the bacterial cell wall is just a protein, and a protein is made of building blocks, mainly the peptidoglycans. So we can inhibit synthesis of these peptidoglycans by vancomycin or bacitracin. We can also inhibit their cross-linking. So you've made these building blocks, you kind of need to cross-link it to make it stronger. And these are by using the beta-lactams, which are penicillins, cephalosporins, carbapenems, or monobactams, and we'll talk about it in more detail. And the last step in killing the bacteria is disrupting the cell membrane using a medication called daptomycin. sort of like punching holes in the cell membrane and make it leak. So out of, believe me, out of the whole lecture of antibiotics, if you understand this slide and internalize it, this will make your life so much easier in terms of understanding the antibiotics. So I would encourage you to spend some time on this slide. Welcome back, and we want to continue our discussion of the antibiotics, and now we're going to talk about cell wall inhibitors. I just wanted to give you an overview first of the bacterial cell wall and some of the important enzymes in it, because the terminology can get kind of tricky, and I want you guys to be aware of some of the terminology. So what is the bacterial cell wall made of? So it's made of peptidoglycan, which is basically a sugar, and it's linked with amino acids. And for example, in Staph aureus, the amino acids, specifically D-alanine. Um, so you have these peptidoglycan sugars, and they're cross-linked. So the peptidoglycans are cross-linked in chains to form a rigid wall. So what cross-links it is an enzyme called transpeptidase. Transpeptidase is the enzyme that cross-links the peptidoglycan to form a rigid wall. Another name for the transpeptidase is called penicillin binding protein. And this enzyme specifically is inhibited by all of the penicillins. So the penicillins, inhibit the cross-linking. And then the third enzyme is called penicillinase, which is also called beta-lactamase, and it breaks down the beta-lactam ring of the penicillin antibiotics. So all of the penicillins have this ring to it, and it's called the beta-lactam ring. Penicillinase is an enzyme that's produced by the bacteria to break down this ring and destroy the antibiotic. And it's a mechanism of bacterial resistance. This enzyme is actually inhibited by inhibitors. So here's the story. The bacteria comes in, we give it penicillin, and the bacteria becomes a little bit smarter and it makes beta-lactamase. Now we try to outsmart the bacteria, and we invented an inhibitor to this beta-lactamase, and it's called the beta-lactamase inhibitor, hence the name. An example of it is clavulanic acid. So this is, the whole picture. So there's the bacterial cell wall, peptidoglycan, cross-linked by transpeptidase, and penicillinase is the enzyme that breaks down the penicillin. So going to discuss the specific medications in the cell wall synthesis inhibitors. So the first class of medications is the penicillin. So penicillins are broken into several types. So the first type is the original penicillin. These are the ones that are made in the 1940s, and were the original medications. So penicillin G and penicillin V. There is also the second generation, which is penicillinase sensitive penicillin. So these are the medications that are broken down by the penicillinase enzyme. So amoxicillin and ampicillin. And the third generation is penicillinase resistant penicillin. So dicloxacillin, nafcillin, and oxacillin. And then there is the fourth generation, which covers Pseudomonas. So these are anti-Pseudomonal penicillins. So piperacillin and ticarcillin. And lastly, there is the beta-lactamase inhibitor. So clavulanic acid, sulbactam, and tazobactam. So these are the types of penicillin. Just a quick point of the side effect of all the penicillins before we go into each specific type is that they can all cause hypersensitivity reaction. And a type of hypersensitivity reaction is, it can be three types. So the first type, it can be IgE mediated, so they can cause urticaria and anaphylaxis. And that's the type that we always hear about when you ask someone and they tell you they have an allergy to penicillin, and you ask them what the allergy is, and they tell you, oh, I get skin rash, I get hives, sometimes I can't breathe. So this is the type 1 hypersensitivity. Type 2 is actually IgG mediated, and it causes hemolytic anemia. So IgG mediated hemolytic anemia. And type 3 is serum sickness like. The penicillin forms complexes with antibodies, and it kind of accumulates and causes serum sickness like reaction. So 3 types with the most common is type 1. So that's a side note for the side effects of all the penicillins. Now talking about the original penicillin, so this is penicillin G and penicillin V. Mechanism of action, as we talked about, it's a D-alanine structural analog, and it binds the transpeptidase. So this is the enzyme that that cross-links the peptidoglycan. So it blocks the cross-linking of the peptidoglycan in the bacterial cell wall. The original penicillin are a little bit of narrow coverage, so they cover some gram-positive, mostly Streptococcus, and they cover some gram-negative, mostly Neisseria, and mainly spirochetes like Treponema, so syphilis. So it's used for strep pharyngitis, syphilis, and dental infections because you cover the strep there. Side effects is that you get the hemolytic anemia, direct Coombs positive. So it's a Coombs positive hemolytic anemia, which is a type 2. Second generation of the penicillins, these are the penicillinase sensitive, say amoxicillin and ampicillin. Amoxicillin is oral, ampicillin is oral and IV. Same mechanism of action, same spectrum as the original penicillin, plus you start getting a little bit more of gram-negative coverage. So Haemophilus influenza, you also get some H. pylori, E. coli, Listeria, and a lot of the enteric gram-negatives. Amoxicillin is used for strep pharyngitis and H. pylori. Ampicillin is mainly used for Listeria, Listeria meningitis, and also group B strep, so either meningitis in the neonates or prophylaxis in pregnancy. Again, I don't want you guys to focus too much on the uses, but it's good to have a general idea for the purposes of STEP. But I think for the purpose of this block exam, it's most important to focus on the mechanism of action and main side effects. Side effects for these penicillins are allergic reaction, like we talked about, and they can also cause C. diff colitis. Mainly with the C. diff, honestly, any antibiotic can cause C. diff colitis, but the ones that I'm highlighting are the ones that have sort of been mentioned in first aid and the ones that are have been highly associated with it. Third generation is the penicillinase resistant. So these medication resist being broken down. So dicloxacillin, nafcillin, and oxacillin. Same mechanism of action as the penicillin. They have a narrow spectrum. The one thing that I want you guys to know is that these medications are the ones used to treat methicillin-sensitive Staph aureus. So Staph aureus can be broken into 2 groups, methicillin resistant or methicillin sensitive. If it's methicillin sensitive, use nafcillin or oxacillin to treat it. It's also used to treat some group A strep, so MSSA infections like I talked about, and it's also used to treat mastitis with dicloxacillin. Side effects, you'll hear about that in when you get into your renal pathology, is they can actually cause interstitial nephritis. So they go into the kidney and they go into the interstitium, which is around the tubules, and they cause some inflammation. The next generation is the anti-Pseudomonal penicillins and the beta-lactamase inhibitors. And we'll talk first about the beta-lactamase inhibitors. And the idea of these is that they protect the antibiotic from being destroyed by the penicillinase enzyme, which is the beta-lactamase enzyme. So they counteract the bacteria protective mechanism. So they have to be combined with the penicillin, which makes sense. So amoxicillin is combined with clavulanate, piperacillin is combined with tazobactam, ampicillin is combined with sulbactam, and ticarcillin is combined with clavulanate. And these are the combinations that you'll see in clinical practice or on your shelf or board exams. But the whole idea is this idea that you're protecting the penicillin from being destroyed. Next is the anti-Pseudomonal penicillin. So these are the piperacillin and ticarcillin. They're very broad spectrum. They have gram-positive coverage, but they don't cover MRSA. And they have some gram-negative coverage, mainly Pseudomonas and like nosocomial infections. So infections that you acquire in the hospital. These medications are combined with beta-lactamase inhibitors. They're used for Pseudomonas infections mainly, and side effects besides the typical, hypersensitivity reaction is C. diff colitis. So, do you guys remember which antibiotic was strongly associated with C. diff colitis? Clindamycin, yes, very good. Clindamycin, some penicillins, but also piperacillin. And piperacillin tazobactam, which is this medication, is probably one of the most used antibiotic in the hospital. It's called Zosyn. So you'll hear that in your clinical rotations. Next class of cell wall inhibitors are the cephalosporins. And I want you to think of the cephalosporins are cousins to the penicillins. They have the same ring, they have the same mechanism of action. It's just they're a little bit advanced. So think about it as like the smarter cousins of the penicillins. And there are 5 generations of cephalosporins, and they're right here. And the idea of the generations is that as you progress in the generation, you start first with gram positive, very strong gram positive coverage, and you lose some of that gram positive coverage, but you gain more gram negative coverage. So you increase the gram negative spectrum of activity. Generation 5 is the broadest spectrum and includes MRSA. Same mechanism of action as the penicillin. It's less susceptible to being broken down by the penicillinase. And the side effects is hypersensitivity uh, as the penicillins and hemolytic anemia. There's a point that I wanted to bring up with the hypersensitivity. So sometimes they'll give you a patient and they'll tell you they're allergic to penicillin. And they'll tell you what medication can cross react, meaning that patient can develop a hypersensitivity if you give it to them. And the answer is cephalosporins, that there is a percentage of cross reactivity with the penicillins, so you have to be cautious when you give the patients cephalosporins. Specific drugs for the cephalosporins. So the first generation is cefazolin. Cefazolin is IV medication, and the oral counterpart to it is cephalexin. Second generation is cefoxitin, and it's IV. Third generation is ceftriaxone, and that's IV or IM, and ceftazidime, which is IV. Fourth generation is cefepime, and fifth generation is ceftaroline. So specific uses for the cephalosporin. So the first generation, which is cefazolin, the biggest thing is that it covers gram positive. So MSSA also has some gram negative coverage. It's used for skin infections and UTIs. It's also used for skin prophylaxis prior to surgery. So when you're doing surgery on a patient, you want to kill the bacteria that's on the skin, and most of this bacteria is Staph aureus or Staph epi. So you give cefazolin. The second generation is cefotaxime. It covers the above plus Neisseria, and it's used for abdominal infections. Third generation is ceftriaxone and ceftazidime. The spectrum is the same, plus nosocomial organisms. This actually crosses the blood-brain barrier. So ceftriaxone is used for meningitis, and it's also used for gonorrhea. Ceftazidime is used for Pseudomonas. Fourth generation is cefepime. So you have increased spectrum as the third generation, plus you cover Pseudomonas as well. And fifth generation is ceftaroline. So that's the broadest spectrum: MRSA, Enterococcus, Listeria, plus all of the gram positive. Unfortunately, it doesn't cover Pseudomonas. I think again, for this, if you have a general idea of the generations, I think you'll be good. You may not need to know the spectrum until a little bit later in the year. Next agent that we're going to talk about is Aztreonam. So Aztreonam is a cousin to the penicillin, but it's a younger cousin. So think of it as the penicillins have 2 beta-lactam rings. The Aztreonam has only 1 beta-lactam ring. It's used for gram-negative rods, mainly Pseudomonas. The biggest thing that I would remember about Aztreonam is that it's used for penicillin allergic patients. So if you have a patient with a true allergy to penicillin, you can give them Aztreonam because it doesn't cross-react with the penicillins. And the reason for that is that it has only 1 beta-lactam ring. Next cell wall inhibitors are the carbapenems. So the suffix for it is penem, and the example is imipenem and carbapenem. Mechanism of action is the same as the penicillin, and I want you to think of the carbapenems as broad and like heavy-duty antibiotics. So they cover gram-positive and they also cover gram-negative rods. It's used for life-threatening gram-negative infections. And the one thing that I want you to remember about the side effects of carbapenems is that it can cause seizures. So I had a question in New World once. It said the patient was in the hospital, was getting a medication, an antibiotic, for healthcare acquired pneumonia, and the patient ended up having a seizure. What medication was the patient taking? And the answer is carbapenem. And out of all the carbapenems, meropenem has the lowest risk. And also a side note that's not like super high yield, but I also wanted to bring it up, is that imipenem is combined with a medication called cilastatin, and cilastatin inhibits imipenem renal degradation because it gets destroyed in the kidney. So cilastatin acts as like a protective mechanism against that. Next cell wall inhibitor is vancomycin, and also vancomycin is one of the biggest medications that we use. It binds to D-ala amino acids. So if it binds to that, it inhibits the peptidoglycan synthesis and it inhibits the cell wall. And it's really important that you know that it binds to these two amino acids. Its spectrum that it covers only gram-positive. Biggest use for vancomycin is MRSA. So vancomycin is in the hospital. You'll see the two biggest antibiotics that are used are vancomycin and Zosyn. Zosyn is mainly for gram-negative coverage, and vancomycin is mainly for gram-positive coverage, specifically MRSA. It's used for MRSA, staph epi, and enterococcus. It can be used orally, but the use for it orally is for C. diff colitis. And the reason for that is that it gets into the stomach and it actually doesn't get absorbed. It stays in the stomach and it kills the C. diff infection. Side effects for the vancomycin is nephrotoxicity, so it goes after the kidney and damages it. It causes some thrombophlebitis, so inflammation of the veins, and it causes this weird side effect called red man syndrome. And red man syndrome is a non-specific mast cell degranulation. So vancomycin goes after the mast cells and causes them to degranulate, so you get this erythematous rash, and the man ends up red or the woman ends up red. Hence the name red man syndrome. And the treatment for it is antihistamines and then slowing the infusion. And that's one of the higher yield points that that examiners like to go after with the vancomycin. Next agent that targets the cell wall is daptomycin. And daptomycin has a weird mechanism of action. It goes to the cell membrane. So all of the other antibiotics that we were talking about were targeting the cell wall. So they were targeting the synthesis of the cell wall. This medication goes after the cell membrane itself, which is like a small layer that covers the bacteria, and it creates transmembrane channels. So it goes and kind of like punches holes in the cell membrane, and if that happens, cells can't maintain their ions. So the ions flow, and then they can't maintain their membrane potential. It's used for gram-positive only, mainly MRSA, VRE. These are the biggest infections that daptomycin is used for. The one thing about daptomycin is that it's actually inactivated in the lungs, so you can't use it for pneumonia. So you can use it for bacteremia, skin infections, or endocarditis, but not for pneumonia. And one of the high yield side effects for daptomycin is that it can cause rhabdomyolysis. So it causes, I think about it as like, this is the drug that punches holes. So it punches holes in the cell membrane, but it also punches holes in the human muscle cells, and it makes them leak the enzyme that's in it, which is CK. So you get elevated CK with daptomycin. And this really covers the cell wall synthesis inhibitors, very high yield for examination, and also high yield for clinical practice. So take a moment, go over what we talked about, and then we'll end up the section with miscellaneous antibiotics and the spectrum of activity for antibiotics and some mechanism of resistance.